My name is Diana Cody, and I'm here to talk to you about the physicist role in CT protocol review. My co-authors on this talk are Mike McNitt-Gray from UCLA and Jim Pofler from the Mayo Clinic. The whole idea of reviewing CT protocol parameter settings may be quite new to you. This is something that has only recently really started to take on a life of its own and become something that lots of different folks are really starting to pay attention to and focus on. In the beginning, if you want to do this, you may need to convince your administration that this process is really needed. Ammunition to do this can be found in some state regulations and recommendations. I live in the state of Texas, and this is now something that is regulated. Starting May 1st, the whole process has been really laid down for us. There's a recent Joint Commission document that talks very specifically about the process of CT protocol review. The American College of Radiology CT Quality Control Manual has some very specific language in there about reviewing some very specific CT protocols. The American Association of Physicists in Medicine professional guideline has been developed to help physicists in their role to review CT protocol parameters. If that isn't enough, perhaps the fear of media reports and subsequent lawsuits might help convince your administration that this is a process that really needs to be initiated and followed through on. You must form a team to do this. We need technologist representation, physicist input, and radiologist involvement. All three components are absolutely critical to this process working at all effectively. Do not try to do this alone. Bad things can happen, and your credibility may suffer if there is no team behind you. I have very specific and personal experience on this score, and I'm telling you it must be done as a team, as a group. So how do you get started with this? Well, first thing to recognize is to figure out if your site has some kind of protocol documentation method, and what is it? Do you do hard copy? Do you have a binder, a master binder, a bunch of binders floating around? Is it digital? Is it file-based? Something in a Word or an Excel document, for example? Is it online? Is it actually accessible through your facility? That would make it easy to access and quick to update. If you haven't really developed your protocol documentation, or maybe haven't done it at all, or don't like it, whatever you're doing now, one thing to think about would be up front, at the beginning, or later on, whatever, add dose information to it. CTDI vol, a range of CTDI vol, something about the expected CT dose for each protocol. We are constantly going back and looking at that number and evaluating it. This is something that I strongly recommend that be inserted into that protocol document. You need to have this review team of the technologist, the radiologist, and the physicist, and probably more than one of some of these members. You may need more than one technologist to back each other up, to provide different perspectives. It will depend on the size of your facility. The radiologist may sort of sneak in and sneak out. Sometimes they get lost in some of the nitty-gritty details and really don't need to participate at that level of detail. But certainly at the beginning, they need to tell the group what's right with the protocol as it stands and what's wrong with it, so that we have an ability to figure out and focus on the things that need to be changed and the things that don't need to be changed. The physicist's role in this particular committee is that they tend to have the best handle on the image quality and dose trade-off. They tend to have the best handle on the technical parameters, what they mean, what are reasonable ranges, and how do they interact with each other. For example, they might have dose intuition. What's too high, too low, or about right for a given exam? They may have much better understanding of this term called effective MAS. They can help you figure out if you're going to change KV, which is a very hot thing to do right now, how to adjust the MA. And, for example, they might be willing to recommend that if you do change KV, you may need to change your trigger HU level for your automatic contrast injection monitoring. These are the kinds of details that physicists can really help with. They can help you decide if you want to use a thick beam on those modern scanners versus a thinner beam. For example, the thicker beam produces fewer scatter rotails, has fewer rotations needed, and tends to be more efficient. On the downside, there are extra rotations on each end of a helical scan, and with a thick beam, this can really cover some substantial geography on your patient and deliver extra exposure that's not reflected on those images. On the other hand, the thin beam has more scatter tails, tends to be less efficient because it takes more rotations to cover the area of interest, but those extra rotations on the ends of the helix will cover less geography and actually deliver less extra exposure to the patient. The cutoff point for GE is 25 to 30 centimeters for their scan extent. So if your coverage is 25 to 30 centimeters or less, you'd be better off with the thin beam. If it's bigger than that, you'd be better off with the thicker beam. These are the kinds of things that a physicist can recommend during these protocol review meetings. If you have patients that have metal implants, what's the best way to adjust your CT parameters? Physicists can give you some recommendations in that regard. They can also act as a technical information conduit by communicating directly with the vendor experts. If you have some very specific questions about a very specific protocol, your physicist can actually represent you with the vendors to get the vendors' perspective on that. Physicists should be able to provide some continuing medical education lectures when requested, especially in conjunction with implementation of new technology when you really need it. I'm going to describe a couple of sites' experience with the process of protocol review, and one is at UCLA. At UCLA, the department chair agreed to tackle CT protocol review. The initial reviews were accomplished section by section. So the neuro group, the chest group, the body group, the MSK group, etc. The chief radiologist for each section was assigned to the team to represent their section. The team also included the CT tech in charge of protocol support, as well as the CT physicist. Every protocol was reviewed one at a time. This was described as both exceedingly painful and incredibly necessary. And this required some time. Many meeting sessions were held with each section chief in order to cycle through all of the protocols under their control. At the end, when everyone was happy with the protocol, it was actually physically signed off by that chief radiologist. This particular slide is of a painting that's called Insanity, because that's where you may feel you're at during parts of this process. This is not an easy or quick process. This can really drag along and be quite painful at times, so don't expect it to be a walk in the park. At my facility, we ran into a basic crisis where the current system was not working very well, and our discomfort level was really growing. Protocols seemed to be changing on their own on different scanners every day. There were far too many to actually try and track and keep track of and monitor. We needed to perform regular protocol updates at some remote sites. And this was all a justification for implementing a much more rigorous and controlled process. And it was really the physics staff who was pushing for this overhaul to actually occur. We were getting more and more nervous about what was happening in the clinic. So our general focus has been on more consistency. We need the image quality to be very consistent across time, across scanners, across technologists. We wanted to design our desired protocol combinations. It's not one parameter that drives any exam. It's the combination of parameters. So we wanted to really look at them all together and figure out the best combination, lock them down on the scanners, discourage on-the-fly adjustments, and instead rely on our protocol inventory. And maybe in the future we'll be able to cut down some of these numbers of protocols by providing a list of guidelines for common issues. For example, what do we do with the super large patient? What do we do with the patient that has metal that wasn't expected? The protocol review process should be done on some regular frequency. My opinion is it should be done at least annually. There may be some regulations in your area that are very specific about this. So I urge you to look into that and adjust your frequency so that you can comply with whatever regulations may be in place. The teams need to review every protocol. And the first question to ask is, do we need this? Is it actually used? This is one of the quickest ways to get through this process is if you can remove the old ones that never get used anymore or that have been replaced. You may be surprised to find some very old historic protocols sort of languishing that have no purpose other than to take up space. So get rid of those. While you're in this review process, look for opportunities to consolidate protocols. Do you really need 5 different flavors of this one protocol? Can't we combine them all into a single protocol and get what we need? You want to look for those protocols where useful new technology such as tube current modulation has not been incorporated yet. You may be surprised at the number of instances that you run into that hasn't happened, where it makes perfect sense, but no one has yet gotten around to it. One of the things that we found very useful, was actually suggested by a vendor, was to add the revision date right to the protocol name. This makes it sometimes really, really easy to see when an older or a newer protocol has been added to a specific scanner. Okay, so now you're knee-deep in the process. What is it that you need to actually look at? You need to look at the acquisition parameters. Do they make sense? If it's an exam that needs to be completed quickly, for example, in a chest, we're looking for probably a lower rotation time, perhaps a higher pitch, so that the breath hold can be kept to a minimum. Those things may not be so important for a head exam, for example, where we can certainly slow things down without any noticeable problems. We want to look at the reconstruction parameters. Right? Is the image thickness appropriate for what the radiologist is looking for? Is the algorithm or kernel appropriate for what they actually need to see? I'm constantly surprised at sometimes the vast number of image reconstructions that are done that are very, very similar to one another. Those are great opportunities for consolidation. We want to check to be sure that we're utilizing all of the dose reduction techniques that we have available to us. Have we implemented two-current modulation? Are we using iterative reconstruction to our maximum capacity? Do we need to do adjustments for patient size? Do we need to implement some additional dose management tools, such as CT dose check? These are all really good characteristics to review while you're looking at each protocol individually. If you're involved in the ACR CT Dose Index Registry program, this is another place to double check that everything is set up appropriately to send that structured dose report to the ACR. There is a professional guideline that should be publicly available in the next month or two from the AAPM that describes this review process. It may give you some additional help. We developed our own protocol management tool at MD Anderson out of desperation, basically. This is homegrown software. It was our third attempt. This time we're using a database structure, and we have defined reference protocol settings that are used to populate our protocol description sheets and are also used to check what is actually available on the CT scanners. And then we should look at the mismatches. So in this way we can confirm that the protocol settings that we desire that are in the reference set actually match what has been loaded onto each scanner prior to each exam. This really helps us track and fix incorrect settings. This is a view of what this tool looks like. As you can see, each protocol name, and here we have different names based on patient size that we set up by their display field of view parameter. Each of these numbers in the green along the top represents a different scanner name, and the zeros underneath tell us that there are no mismatches between the reference protocol shown in the sheet link and the set of parameters that are actually living on the scanner. So you can see in this particular example, under our pulmonary embolus protocols, we see that there is a mismatch on this particular scanner called CT2. These mismatches are highlighted in yellow, and that's shown in the next slide. This is our protocol document. So this is the descriptive page that we build based on this database that we are using. And so here you can see that there was actually more than one mismatch. One had to do with the name of the protocol, another had to do with the dose value that's shown here, and another had to do with the interval between images set on this third reconstruction set. So this is a tool that we've developed as part of our CT protocol review process. So as you embark on this process, you're going to want to decide what's your big picture approach here. You can start out deciding that we only need a few basic protocols so that there won't be so many to keep track of and to review. This would, however, require a lot of adaptation by your technologists for anything that's not routine. That will likely result in quite a bit of variation in your technique and in your image quality. It also may slow down the throughput because it takes some deciding and some doing to actually adjust many of these parameters. But that kind of approach might work very well for certain types of practice. The other approach would be to require a large number of protocols. This then means that there are a lot of protocols to monitor and to review long term, but it allows you to develop different parameter combinations for different scanner models and for different exams. And then you can take advantage of some of the newer features of some of your newer scanners that way. This would hopefully improve your throughput and hopefully improve your overall consistency. However, it doesn't take very long for version 2, having a lot of protocols, to go completely out of control. When we started our process, for example, we had a protocol for chest exam without IV contrast, a separate protocol for a chest exam with IV contrast, and a third protocol for a chest exam with and without IV contrast. So 3 protocols where the basic technical parameters should have been exactly the same. So what we've done is combine all those, consolidate them into a single protocol that includes the chest with and without IV contrast, and we ask the technologists to delete the passes that were not specifically ordered on the fly. It doesn't take very long to remove things. What takes a long time is to change, modify, and add things. Another confounder can happen if you're being very careful about patient orientation. We've had a problem on some scanners that true current modulation actually becomes disabled if you tell the scanner after the exam has started that the patient is actually positioned in a different manner than the scanner assumed. Sometimes they disable true current modulation and the warning is not picked up. So in that case, we had chest exam with and without IV contrast with the patient put V first, and a second protocol for them put in head first. So again, doubling the number of protocols that you need to actually monitor and review. This is a vendor-dependent thing, but it's something you need to keep an eye on. The newer scanners seem to be able to deal with this much better. From UCLA, they decided that they were also in the inventory of protocols approach was better. And as they went through this review process, they realized that for some protocols, they could reduce dose and maintain acceptable image quality. This is a good thing. This is what we all hope to get. But for some other protocols, they actually needed to increase their dose to achieve the desired image quality. This happens. Expect this to happen. Don't expect that this review process is going to automatically reduce your dose overall. It may not happen. It should produce more consistent and more acceptable results, but dose isn't automatically going to decrease. So for example, at my facility, we had a new protocol that was actually developed without physics and radiologist input. The technologists needed this on the fly and just went for it. This was, the idea here was to insert a needle in a specific place in the neck under CT guidance. And they decided that the routine spine protocol was a good place to start. And overall they did a pretty good job, but the reconstruction algorithm that was chosen was not really optimal for soft tissue. And they used, there was a question about whether the large scan field of view versus the head scan field of view was more appropriate for that particular exam, and whether or not 140 kVp would have been a better choice to eliminate some of the metal artifact from the needles. If you have a new scanner coming in with new features, some phantom scans may help to understand the effect of these new technologies prior to clinical implementation. This is a place where your physicists and technologists can work together to really figure out how some of these new features are going to work. And then together with the radiologist can employ some new features in your clinical scan protocols. So what does the physicist do during all this? Well, they really want to focus first on the dose parameters. CTDI vol, kVp, tube current, rotation time, and pitch, the width of the beam, the detector configuration, tube current modulation parameters, which vary by vendor, and some vendor tube current modulation approaches are very, very sensitive to that primary or first image thickness value that's programmed in. This is another place where the physicists tend to be very compulsive and neurotic because it can really drive dose really high or really low if that's not very carefully controlled. Target is to have image quality consistency for different scanner vendors and models. For aggressive or more higher dose exams, we can ask the radiologist which parts of the exams can be done at reduced settings. Very often, the entire exam doesn't need to be super aggressive, but maybe 1 or 2 passes can be identified as the more critical ones. We can introduce the idea of dose budgeting, sort of having an overall target for the entire exam and deciding which passes deserve a bigger part of that pie and which ones can be done with much, much less dose. We can also encourage enhancement delay compromise to eliminate one pass completely and avoid overlapping regions. So if we can, instead of having a 3-pass exam, compromise on one of those passes in there and eliminate one completely, that reduces dose in a big way. If we can be stingier about overlapping the edges of the exams, we can also benefit our patients. Physicists can provide some reference protocols that can be used as guides. The AEPM website has a CT protocols button that has a set of standardized protocols that can be used as reference. Other websites like ctisus.com can be used to, again, develop intuitive ideas about how our particular set combination of parameters compares to other people, what other folks are doing. You can use your vendor technical contacts to get suggested values for specific exams, and you can ask your radiologists and physicists to ask around, swap some information with their colleagues. And there's always conferences that are very good about sharing that kind of data, like RSNA, like the APM CT Dose Summit, venues like that. And I hope that gives you an idea of how to approach CT protocol review, and I'd be happy to take any questions.